If you are a medical student, a young healthcare professional, or just an insanely curious learner, I want you to imagine two children.
Okay.
Both are diagnosed with the exact same type of cancer. Like, the biology of the tumor under the microscope is absolutely identical.
Right.
But here is the startling contrast. The child living in a high-income country has an over 80% chance of survival. But the child living in a low or middle-income country, an LMIC, has only a 20% chance.
Yeah, it's a devastating reality to confront. And it really forces us to look far beyond the microscope,
But exactly.
Because the actual science of treating cancer, the molecular biology, the targeted therapies, that's advancing at lightning speed.
Mhm.
But the physical delivery of that science is just profoundly unequal across the globe.
Right. And today we are unpacking a massive, comprehensive blueprint that's actually designed to fix that exact problem. We are diving into a book called Improving Oncology, Worldwide Education, Clinical Research, and Global Cancer Care.
It's a heavy hitter.
It really is. It's edited by Ute Schmidt-Strasberger, and it is actually part of the United Nations Sustainable Development Goals series.
Which tells you right away that this isn't just a clinical textbook listing drug dosages.
No, not at all.
It is a strategic manual. As a medical educator, I always tell my students that to truly understand the field of global oncology, you have to look at the entire ecosystem.
Yeah.
We can't just talk about the newest immunotherapy drugs. We have to look at how oncologists are educated in the first place, how mountains of complex clinical data are synthesized, and, how patient care is physically delivered across wildly different economic landscapes.
Okay, let's unpack this, because we have to start at the very beginning.
Right.
Before a single patient can be treated or a clinical trial can even be designed, there has to be a trained physician. But how do you ensure that a doctor in Berlin and a doctor in Luxor are speaking the exact same scientific language?
Well, you have to start with a harmonized education. Historically, oncology training across the globe has been incredibly fragmented.
I can imagine.
In some countries, medical oncology is a distinct, highly protected specialty. In others, it's sort of casually merged with hematology or radiation or even just general internal medicine.
Wow, really?
Yeah, and that creates massive inconsistencies in patient care. So the European Society for Medical Oncology, ESMO, and the American Society of Clinical Oncology, ASCO, they collaborated to create a standardized global curriculum.
And it sounds like the ESMO and ASCO curriculum is trying to be a universal operating system for oncology.
That is a brilliant way to conceptualize it, actually. It's this 240-page blueprint that outlines exactly what an oncologist needs to master. And what's brilliant about it is how it defines competence.
How so?
It doesn't just ask if a doctor read a chapter. It breaks competence down into 3 distinct levels: awareness, knowledge, and skill.
Okay, give me an example of how those 3 levels actually play out in a clinic.
Sure. So let's take a complex targeted therapy for lung cancer. Knowing that the drug exists and what it generally does, that is awareness. Understanding the underlying molecular mechanism, like how it binds to a specific cellular receptor, that is knowledge.
Right.
But safely administering that drug, actively managing the severe toxicities when the patient's blood counts drop, and, communicating the prognosis to a terrified family, that is a skill.
Yeah, that makes total sense. And a universal curriculum ensures a doctor has all 3. But delivering this universal operating system globally means you have to overcome some serious geographic barriers.
Absolutely.
The source material highlights Ulm University's Advanced Oncology study program. They developed a blended learning or a B-learning approach to get this curriculum to doctors everywhere.
Yes, and it's a highly effective model. It combines asynchronous online modules with intense in-person clinical workshops.
Oh, that's smart.
Yeah, they break the entire field down into 4 core modules: interdisciplinary oncology, clinical research, advanced therapies, and crucially, management.
The management piece caught my eye. They're teaching medical doctors health economics, quality control, and how to actually run a clinic.
Which is vital.
But here is where I struggle with the concept of a universal curriculum. How can a standardized educational benchmark realistically work when a resident in Germany has access to cutting-edge tech and a resident in Iraq is navigating wartime infrastructure?
Yeah.
It feels like trying to run your brand new software on completely outdated hardware.
Well, if we connect this to the bigger picture, the curriculum isn't meant to be a rigid straitjacket. It provides a flexible benchmark.
Okay.
The core biology of a tumor, the principles of how radiation affects human DNA, the pharmacokinetics of chemotherapy, those remain constant regardless of the resources available in the room.
That's true.
And that is exactly why local adaptations of this curriculum are so critical. The curriculum provides the gold standard, but local champions have to figure out the mechanics of applying it.
You actually see this tension playing out perfectly in Egypt right now. Dr. Zainab El Said and her colleagues are doing the incredibly heavy lifting of separating clinical oncology into distinct medical and radiation specialties to meet these modern ISMO and ASCO standards.
Right, it's a huge undertaking.
And they are building specialized local networks, like a national sarcoma network, just to pool their limited resources and expertise.
And if you want to look at the sheer grit required to adapt this curriculum, look at the achievement in Iraq by Dr. Laith Mullah Hussein. It is nothing short of astonishing.
Oh yeah, launching the first board-certified radiation oncology program at the Zianowa Cancer Center, right in the middle of a war-torn country.
Exactly.
How do you even begin to do that when the power grid might fail or the supply chains are completely broken?
You get incredibly resourceful. They utilized the global curriculum as their foundation, but they had to solve massive logistical hurdles.
Like what?
Well, to maintain international standards, they collaborated internationally to bring in visiting examiners. And when flying them into a conflict zone was too dangerous or just logistically impossible, they utilized secure digital platforms for oral examinations and case reviews.
Wow.
Yeah, they essentially created a pipeline of highly trained specialists where absolutely none existed before, all while navigating a conflict zone.
It just proves that the human element really is the ultimate hardware in this system.
It really is.
And speaking of the human element, the sources also highlight an initiative in Portugal by the Nucleus of Interns and Young Specialists, or NIJE. They recognized a massive gap in the standard curriculum regarding the day-to-day emotional reality of being a young doctor.
It's a vital initiative. They launched an 8 months, 8 courses project to cover often overlooked clinical skills. They focus heavily on managing acute oncological emergencies, but perhaps most importantly, they focus on oncology communication.
Because breaking bad news to a patient isn't just having a chat, it is a high-stakes clinical procedure.
Precisely. It is a procedure, just like a biopsy or placing an IV. It requires formal training to do it without inflicting unnecessary psychological trauma on the patient.
You're right.
And frankly, without destroying the doctor in the process. By focusing on this, along with concrete strategies to combat physician burnout, they are ensuring this highly trained workforce actually survives the emotional toll of the job.
So we have built this army of globally trained doctors. But what happens when the textbooks they learned from are suddenly outdated by millions of new data points? How do they know what medical evidence to trust? A trained doctor is only as effective as the data they rely on.
And the current data landscape is entirely overwhelming. We are talking about over 1 million scientific papers pouring into PubMed every single year.
That's insane.
The medical community is drowning in an avalanche of uncurated data.
So reading the latest research used to be like drinking from a water fountain, and now it's like drinking from a fire hose at 2 papers per minute.
That's exactly what it is.
But isn't expert consensus how medicine has always worked? You know, a group of brilliant minds get in a room, look at the pathology slides, and agree on a classification. Why the sudden push to replace a room full of experts with rigid data algorithms?
This raises an important question, and it is a very common misconception. Evidence-based pathology doesn't replace experts. It empowers them. Historically, cancer classification, like the famous World Health Organization Blue Books, relied heavily on that expert opinion. But human beings, even brilliant ones with decades of experience, have inherent cognitive bias. There is inter-observer variation.
Meaning 2 experts can look at the exact same tissue sample and disagree.
Exactly. One pathologist might look at a cellular structure and call it a grade 2 tumor. Another expert in a different country might look at the same slide and call it a grade 3.
Oh, wow.
And a grade 2 might mean watch and wait, while grade 3 means initiating highly toxic chemotherapy tomorrow. It completely alters the patient's life.
So how do you eliminate that human bias?
The WHO and the International Agency for Research on Cancer are pushing a rigorous evidence-based approach through initiatives like the EVPAT training program and the IC3R collaborative.
Okay.
They're giving experts a standardized lens by utilizing rigid reporting guidelines. 2 major ones are STARD, which is used for diagnostic accuracy, and TRIPOD, which is used for prediction models.
So for those of us who aren't data scientists, how do STARD and TRIPOD actually work in practice?
Think of them not as restrictive rules, but as universal, highly detailed recipe cards or checklists.
Oh, I like that.
If a researcher in Peru and a researcher in Germany both use the STARD checklist to report their findings, they can guarantee they are measuring and documenting diagnostic accuracy the exact same way.
It's not apples to apples.
Exactly. It allows researchers globally to pool complex molecular, genetic, and digital pathology data completely objectively, stripping away the human bias.
They're essentially creating a common structural language for research, just like the ISMO and ASCO curriculum did for education.
Spot on.
And when you structure data properly, you can find incredible hidden truths. The source material highlights Dr. Ahmad Samir Alfar's work with cancer registries. Now, you might think a registry is just a boring administrative list of who got what cancer. But by data mining these registries, his team found something deeply profound.
Yes. His research revealed a significant, measurable spike in suicide rates within the first 3 months of a severe cancer diagnosis.
That's heartbreaking.
It is. And this was specifically found in patients diagnosed with cancers that have historically poor prognosis, like pancreatic or advanced lung cancer.
And the most crucial detail here is that this spike happens before the treatment results are even known. The psychological weight of the word cancer alone is the trigger.
And that is the immense power of a well-maintained tumor registry. It takes a tragic clinical anecdote, a doctor noticing a patient struggling, and turns it into actionable, undeniable epidemiological data.
Right.
Because of that specific finding, hospital systems know they need to drastically alter how psychosocial support is applied. You cannot wait to see how the patient handles their first round of chemotherapy. The psychological intervention must happen the very moment the diagnosis is delivered.
It fundamentally changes the standard of care. We also see this data-driven approach shattering old assumptions in Carlos Castaneda's work in Peru.
Yes, his work is fascinating.
We so often assume that the reason breast cancer outcomes are worse in lower-income regions is purely socioeconomic. We blame it on a lack of mammography machines, delays in getting to a clinic, or the high cost of drugs.
But Castaneda's molecular and cellular analysis proves that it is not just socioeconomic. By looking at the hard genetic data, his team found higher prevalences of aggressive tumor biological features in certain Peruvian populations compared to North American cohorts.
Meaning the tumor itself is biologically more aggressive, completely independent of the patient's bank account.
Precisely. And this proves the absolute necessity for diverse global genetic data.
Yeah.
If we only base our molecular understanding of breast cancer and the drugs we develop to treat it on genetic data harvested from North America and Europe, we are entirely missing critical biological realities that affect millions of women elsewhere.
We really are. Okay, so we have the globally educated workforce. We have the rigorous, unbiased, diverse data. But how does all this theory and evidence translate into actual physical care for the patient?
That's the big question.
Because eventually, a doctor has to put a physical drug into a physical patient. And that is where economic realities hit incredibly hard.
This is exactly where the rubber meets the road. And the infrastructure gap we see globally is just jarring. Dr. Atarnitikim outlines the stark realities of radiotherapy access in Nigeria.
Yeah, the numbers here are staggering.
Earlier, we established that a high-income country like Canada has more than 5 radiotherapy machines per million people. In LMICs like Nigeria, there is less than 1 machine per million.
Less than one. For a population of over 200 million people, the logistics of that are terrifying for a patient. You aren't just driving across town, you are traveling hundreds of miles.
It leads to patients traveling immense distances only to arrive and find the machine is broken down, and the proprietary replacement parts will take months to arrive.
Oh, man.
Many abandon treatment altogether due to the staggering logistical costs, and it causes a massive brain drain. The very few trained medical personnel are so overworked, constantly fighting a broken system, that they eventually burn out and leave for high-income countries.
How do you even begin to stop that bleeding?
Well, Nitikim stresses that it requires a multi-pronged approach. We need universal health insurance models to make the treatment affordable for the patient, but we also need international collaborations to support the doctors.
Like what?
Programs like St. Jude's Cure for Kids are vital. They allow experts in high-income countries to remotely assist local doctors with complex pediatric cases, essentially sharing the cognitive burden and keeping local doctors supported.
Oh, that's incredible. It is about building clinical capacity without having to build a massive physical hospital overnight. But what happens when you do need to scale up physical care for a massive population? This brings us to Dr. Ninad Kader's breakdown of the National Cancer Grid, or NCG, in India.
Yes.
This is an incredible network of 253 centers. They utilize what is called a hub-and-spoke model.
Which is an incredibly efficient way to manage limited resources across a vast, heavily populated geography.
The way they organize it sounds exactly like a major airline network.
Right.
You use the smaller, local regional hospitals, the spokes, for everyday, routine needs, basic chemotherapy, standard biopsies, routine follow-ups.
Right.
And you strictly route the highly complex, rare surgical cases to the massive central apex centers, the main hubs.
It prevents the highly specialized main hospitals from being overrun with routine cases, and it saves the patient from traveling 1,000 miles just to get a basic blood draw.
Exactly.
It is brilliant, scalable logistics. And they pair this structural model with the Make in India initiative, which heavily promotes the concept of frugal innovation.
Right.
A prime example of this is the practice of safely sterilizing and reusing single-use surgical devices to drastically lower the cost of interventions.
Okay, I have to pause you there because I know what our listeners are thinking.
Yeah.
As a patient, hearing that a single-use surgical device is going to be washed and reused sounds absolutely terrifying.
Mhm.
How does the medical community justify taking that kind of risk?
What's fascinating here is the data behind the practice. The medical community justifies it because it isn't a risk when governed by science.
Yeah.
They utilize incredibly rigorous, itemized, standard operating procedures, or SOPs, for sterilization. We are talking about multi-step autoclave protocols that completely eradicate any biological material.
Wow.
The scientific reality, backed by extensive studies in these environments, is that when these strict sterilization protocols are followed to the letter, patient morbidity and infection rates do not increase at all.
Wait, really? So the clinical outcome, the safety of the patient, is exactly the same as if they used a brand new device out of the plastic.
Exactly the same. But the economic outcome is completely transformed. By safely reusing a surgical device that might cost several $100s, the overall cost of the surgery plummets.
That's massive.
And when you are treating a patient population where many individuals may be living on less than $10 a day, that frugal innovation is the literal difference between getting a life-saving tumor resection and being sent home to die. It expands access exponentially without compromising safety.
That reframes it completely. It's not about cutting corners in a dirty room. It's about maximizing resources through rigorous science to save lives.
Exactly.
But maintaining that high-level quality control is still paramount. We see the friction of implementing quality control in the private sector and outpatient care as well. The source material details how the Oncoclínicas group in Brazil successfully implemented the American Society of Clinical Oncology's QOPI certification.
Yes, the Quality Oncology Practice Initiative. It is a notoriously rigorous standard.
And it wasn't easy. Implementing an American standard in a Brazilian outpatient setting comes with massive friction. You have to adapt the protocols for local drug availability, completely retrain the nursing staff on foreign administration techniques, and, force a cultural shift where a lone wolf surgeon actually has to communicate with a medical oncologist before making a move.
Right, which is no small feat.
But they did it. They established strict protocols for chemotherapy preparation, drug administration, and multidisciplinary communication.
It serves as a proof of concept. It proves that international quality standards can be successfully transferred and maintained in middle-income countries if the institutional will is there.
Yeah.
And that specific pursuit of multidisciplinary quality culminates in what we call comprehensive cancer centers, or CCCs. Dr. Thomas Soferlane breaks down why these institutions are considered the absolute gold standard of care worldwide.
When you say comprehensive cancer center, I instantly picture a massive, incredibly expensive, shiny new hospital, which is the exact thing we just established that LMICs cannot afford to build. So how is a CCC actually different from a normal hospital, and how is it scalable?
That is the perfect question to ask. A CCC is not defined by the building. It is defined by the integration of its services. It is a unified powerhouse of care.
Okay.
It is not just a place where a surgeon operates in a vacuum. A true CCC mandates regular, multidisciplinary tumor boards where surgeons, medical oncologists, and pathologists sit in a room together and debate every single case.
Oh, wow.
They maintain well-annotated biobanks to fuel local translational research. They run active clinical trials.
Yeah.
And crucially, they integrate robust outreach activities, things like nutritional counseling and psycho-oncology, right into the patient's daily care plan, rather than treating them as afterthoughts.
So what does this all mean? We've gone on quite the journey today. We started with the absolute necessity of a standardized global educational curriculum, giving doctors everywhere a shared biological language.
Right.
We moved into the evidence, how WHO tumor classifications and massive, meticulously kept data registries shift us away from human bias and toward objective, universally understood science.
Exactly.
And finally, we saw how frugal innovation, highly efficient hub-and-spoke models, and the integrated care of comprehensive cancer centers physically deliver that science to the patient.
It paints a very clear picture. It shows us that the global fight against cancer is an entirely interconnected ecosystem. You cannot fix one piece without addressing the others.
To all the young medical professionals and insanely curious learners listening, a breakthrough in understanding tumor molecular data in Peru, combined with a frugal, cost-saving care delivery model developed in India, scaled by a standardized educational curriculum written in Europe, could dictate the future of oncology worldwide.
It really could.
The solutions are out there right now. They just need to be connected.
Before we wrap up, as a medical educator, I want to address you, the listener, directly. Let's reinforce what we've unpacked today with a short clinical scenario.
I like this.
Imagine you are tasked with setting up a brand new oncology network in a middle-income region with severely limited resources. Based on our deep dive today, what are the 3 foundational pillars you must establish first to ensure sustainable, high-quality care? Take a second to think about it.
I am mentally reviewing the whole deep dive right now.
Well, think about the ecosystem we just explored. First, you must implement a standardized educational curriculum, adapting something like the ESMO and ASCO guidelines so your local workforce speaks a universal clinical language.
Right.
Second, you must establish a tumor registry to gather local epidemiological data. You cannot effectively treat a population if you do not measure what is actually happening to them.
Makes total sense.
And third, you need to set up a hub-and-spoke multidisciplinary care model to maximize your limited physical infrastructure and personnel.
It is a phenomenal blueprint for the future, and it leaves me with one final mind-expanding thought for you to chew on. If we are successfully standardizing these global oncology protocols, and if we are utilizing digital pathology to share microscopic tumor evidence instantly across oceans, could we one day see the rise of a truly borderless, decentralized digital hospital?
That is a fascinating idea.
Just imagine a reality where a patient sitting in a remote rural village in Nigeria is diagnosed locally, but their highly complex treatment plan is debated and directed by a synchronized global tumor board happening in real time across 4 different continents.
Wow.
If the knowledge is universal and the data is digital, the world-class expertise no longer has to be locked inside the walls of a high-income hospital. We can finally close that gap between an 80% survival rate and a 20% survival rate. Think about that. Here's where it gets really interesting. Until next time, keep diving deep.